You may have heard reports of an HIV cure presented here at CROI 2019 yesterday. We're going to talk about that and more. My name is Anne Rancourt, and I'm here for HIV.gov, and I'm with Dr. Carl Diefenbach, Director of the Division of AIDS at the National Institute of Allergy and Infectious Diseases. Carl, thanks for joining me.
It's great to be here at the second day of CROI.
So there are reports in the media of a man in London whose HIV has been in remission for 18 months without treatment, and many in the media are calling this a cure. And so, Carl, I want you to put that into context for us. But first, tell us a little bit about this individual and what has happened to him.
Let me tell you what we know. So the individual has had a very serious form of cancer, and the cancer could not be controlled by standard antiretroviral therapy. So at the end of the day, what was required to treat that patient was a stem cell transplant or a bone marrow transplant. As such, they were able to find a donor that had these specific genetic properties that allowed that individual's immune system to be reconstituted, to be rebuilt using material that was genetically resistant to HIV. Long story short, the transplant took, not a lot of graft versus host disease, came out the other side with a new immune system. After looking at the individual's responses, the doctors talked to the patient and they decided to stop therapy. They stopped therapy 18 months ago, and that individual's viral load has not rebounded in 18 months.
And so bone marrow transplant, stem cell therapy, finding a donor, are these difficult things, hard to go through?
They are, well, again, so when you're dealing with a lethal disease like cancer, this is often what we are left to do to help keep people alive. You know, the standard chemotherapy tends to be harsh, but this is so much worse. I mean, the treatments are difficult, and to give you a perspective, there have been 2 people now that appear to be in virologic remission after these kinds of transplants. As far as we can tell, the number of people that this has been attempted in are in the order of 20 or more. So the denominator on this is significantly larger than the numerator, and so it's not the standard of care. It's not for the faint of heart, and it's only really to be used in situations where you cannot achieve the prevention of the cancer by standard means.
And so what we heard reported here at CROI and what folks are seeing in the media, is that scalable to be something that can be applied to many folks?
It's not even scalable for cancer. I mean, it is really still an art form and only can be done in the major medical centers around the globe. So it remains, it's not a research tool, but it's the treatment of last resort, as it were.
And so an actual cure for HIV would be so meaningful to so many people living with HIV and absolutely life-changing. And I was speaking with an activist who's here at CROI who's living with HIV, and he was saying that when this news broke, he started getting text messages and emails and phone calls from friends and family saying, "I'm so happy for you, this is wonderful news, this is going to change your life," folks thinking that his HIV was about to be cured. How do we talk about scientific findings like this in a responsible manner that help frame it for folks living with HIV?
I think it's really important that we understand that this is part of a research area of what we call a cure or sustained virologic remission, and each one of these little data points adds to it. But it doesn't change the fact that we are here today in 2019, we have amazing antiretroviral drugs, which when taken reliably, with 1 pill once a day, people can live normal, happy lives, and U equals U rules. That's the key. In some ways, you are essentially, as long as you take your medicine, there's no virus for you to contend with. So there's a balance here, is that yes, there are people that are really seeking a cure, but at the same time, we have to do this in a coordinated scientific manner and not rush out and give people false hope. Like some of the journalists have done. I think we have to really take this in stride about where we are in this research agenda. And this is important, but it's not the game changer.
And in terms of the research agenda, you said earlier this week that we are at the end of the beginning when it comes to cure research. Can you tell us a little bit more
So
about that?
I think we have to think about, and as part of being at the end of the beginning, is where are the little signals, the small um, areas where there's progress to be made. And two of them I think are worth highlighting. Last night, as part of the opening session, Michelle Nussensweig from Rockefeller University talked about work that he has been doing with his colleagues Marina Kasky and the folks at Rockefeller, looking at the effect of antibodies in HIV positive individuals and also for monkey studies. And they're seeing some pretty profound effects that are not just the traditional antibody as a drug, but maybe there's some tweaking of the human immune system that's occurring with the antibodies. And he reminded everybody that this goes back to the beginning of the last century, where diphtheria toxin led to a form of treatment that really helped cure diseases in terms of using serum, using antibodies. The other thing that was a really interesting finding that I don't want people to lose sight of was the first really profound experiment, it seems it's been reported, using CRISPR-Cas9, which is a gene editing technology that holds great promise, not just in HIV, but in other diseases. And the group at Temple University put a CRISPR-Cas9 system into non-human primates and then looked to see where the system went and its impact. And it was actually surprisingly effective. So that gives us hope that maybe down the road, CRISPR-Cas9 could be used in people in a similar way. But again, it's early days. It's what we need to do those critical experiments first in animals, understand the safety in animals, and be able to really understand what the impact was. So it's a good start.
Great. So switching gears a little bit to talk about test and treat. We heard final results from the Pop Art study here yesterday. Tell us first, what is test and treat?
So I have not heard the phrase test and treat since the Greenwich paper came out, 2011, 2012. People have moved on from the phrase of test and treat to treatment as prevention, universal testing, universal treatment. But it's all part of the same. What we're about is identifying people who are HIV positive, getting them into care, getting them engaged in care and on treatment so that they suppress their viruses. And I think that what we saw out of the question that Pop Art was to ask is, can universal test and treat, or the delivery of antiretroviral therapy, get enough people on therapy and virally suppressed to have an impact at a population level now? That's what Pop Art is, population antiretroviral therapy, to give us a signal that at the population level you can reduce incidence. Long story short, what was seen in this experiment is that in the communities receiving the intervention arm, there was about a 30% reduction in incidence compared to the control arm. So that's a big step forward. There have been 4 or 5 of these studies. This is the first to show a statistically significant, and beyond just a statistically significant, a biologically relevant effect on HIV incidence. So it's a big step forward.
And when we see results like this, the study was done in 2 countries in Southern Africa. Can we draw any parallels here in the United States?
I think that's a really important question, and the answer to that has to be yes. If you think about what the Pop Art intervention was, it was about improving the access to care. And if you think about the challenges we face in the United States, where you have large jurisdictions where there isn't good access to care, how can we, as we move forward, improve access to care? If we believe that health care is a right, and I think access to good health should be a right and should be viewed as a right, how can we build the appropriate systems so that health care as a right is available to people so that they can get the necessary medications and visits from doctors so that they can live normal, healthy lives?
And so talking about another kind of testing that's very important, viral load testing, which is different than the test to determine if you are HIV positive or HIV negative. What is viral load testing?
So viral load testing, so if you think about the viral load in the body, so the amount of virus that an individual has in their body at any given time is a degree of how fast their disease is progressing. So if you think about somebody with a high viral load, they're on a speeding train. If they have no viral load, the train is stopped. So the goal is to stop the train. So in some ways, the ability to measure in real time the virus that is present in an individual gives us the tools to say, you're in good shape, you're living the life of U equals U, go forth and have a great time. So this is why that is such an important test.
And so this is an area that is really ripe for innovation since it delivers such an important
It really delivers
piece of
an important
information.
piece of message to the individual. So in the ideal situation that what we heard about at this conference is a point of care viral load test. So a person comes in for a clinic visit. The very first thing that happens is there's a blood draw, and then the blood migrates out of the clinic office into a machine, magically, of course, and then within 3 hours, their test result is available. And so what we have seen is that when patients are willing to wait to hear that result, and in many ways it's affirming. I'm in good shape. I've remained virally suppressed. Oh, I'm having trouble. I need to rethink how I'm adhering to my medications. It's real-time follow-up at the time of your doctor's visits. It's when an individual is open to suggestions on how to do things, either stay the same because thumbs up, you're in a good way, or you need to improve and double down on adherence. And the difference is, in the study we heard about today, was either you get it the same day or you have to wait 28 days or a full month or longer to get that result. And what we saw was, surprise, surprise, earlier access to the information made a statistically significant improvement in people's outcomes. So that's another example of we need to be able to innovate that domestically as well as internationally. And ultimately, the ideal would be if there was a home-based test kit for viral load. You could think of it as a dipstick that if you had a positive virus in your bloodstream, you could do a sort of like glucose. You test it. If there's a plus, you know that you actually need to either see the doctor or start taking your pills more reliably. If there's no signal, you're good. Just keep doing what you're doing.
Great. And are there next steps on this?
Well, we're busy trying to figure out how to build something that's simple and scalable and affordable that could be done in the home.
Great. Carl, thank you for joining me. As always, we will be back tomorrow with more from CROI 2019 here in Seattle. In the meantime, check out hiv.gov for more information, and don't forget to tell us where you're watching from and leave your comments and questions. Hopefully we can answer those when we're back tomorrow. Thank you for watching, and thanks, Carl.